Assalamu alaikum. First of all, thanks for the organizing committee for the invite, and thanks for the audience for staying late. Following the introduction of the transcatheter technique for aortic and mitral valve disease, the possibility of lower risk transcatheter valve intervention became more attractive. However, the development of transcatheter devices for TR treatment faces several anatomical challenges. Among these challenges, the frequent presence of large tricuspid annulus size, thin and more delicate valve leaflet, often with the deep cleft and folds and different leaflet morphology, lack of calcium for device anchoring, the angulation between the tricuspid annulus, the inferior and superior vena cava, majority of the time is difficult, and the frequent presence of pacemaker defibrillator leads. And numerous catheter-based devices has been in the market for years and designed and underwent clinical and preclinical testing. And majority of them did not get into the final stage. And among them, the cooptation devices has shown to achieve effective TR reduction and resulting in significant clinical improvement, and that include Pascal system and the TriClip. Transcatheter valve repair system evolved over years, with the first compassionate use of mitral clip with case series of 13 symptomatic patients with severe TR. All patients experienced TR reduction. Functional class improved in 84%. Only one major adverse event was observed, which was stroke. Year after, we start using the NTR and the XTR, and a study done in 64 patients, 88 of whom had functional TR. 34% of the TR was treated at the time transcatheter repair of the MR. Acute procedure success was achieved in majority of the patient, 97%, with a reduction in TR severity by at least 1 grade in 91%. 3 in-hospital death was observed. In 2018, the famous TriValve registry included 249 patients with severe TR treated with a mitral clip in 14 centers in Europe and North America. Successful procedure, which defined as a 2+ TR grade, was achieved in 77% with a placement of average of 2 plus or minus 1 clips. At this stage of evolution and learning process that we already built from the previous experience, cumulative evidence were built up to target the right cohort. Moving from retrospective registry to more analyzing the data, Bissler et al. Analyzed the predictive procedural outcome in 117 TR patients treated with a mitral clip and found that smaller EROA, tenting area vena contracta, and coaptation gap, along with the central and anterior septal jet, were the predictor of procedure success in the univariate analysis. And only the coaptation gap was the only positive predictor in the multivariate analysis. Another study to look for the underlying cause using the mitral clip XTR, which is feature 3 millimeter longer arm, in patients with a coaptation gap of more than 7 millimeter, the overall procedure success dropped to 75%. Single leaflet clip detachment was observed in 4 patients with more than 7 millimeter coaptation gap. At this point, we started to understand and better select patient for the TR. So better echocardiographic criteria built up during this time. Not only this, but the innovation in the field led to introduction of the TriClip system. In the past, we used only compassionate use of mitral clip to treat TR, but in early 2020, we start using the TriClip system. In contrast to the standard mitral clip system, the steerable guide catheter from the TriClip design has 2 knobs. If you can see, the S and L knob enable movement in the septal lateral direction, and the other knob is plus or minus is to provide high need above the valve plane. The other knob, the flexion extension knob, used to steer down the valve plane, and actually this is for the 4G system, not the TriClip. So the difference is using, similar to MitraClip, is using of the independent grasper to grasp the leaflets independently. Also, the addition of the two clips, the NTW and XTW wider clip. So after this introduction and going through the evidence, so was the prime time to conduct a clinical trial, and the triluminate pivotal trial was a prospective single-arm multi-center study evaluating the TriClip system in patients with moderate severe TR who were randomized to transcatheter the tricuspid valve repair or guideline-directed medical therapy. Acute procedural success was observed in 90.5%. TR severity was moderate or less than 57 at 30 days and 6 months. The trial met the primary safety endpoint. Only 3.7% of patients had a major adverse event at 6 months, significantly less than the specified performance goal of 39. TR reduction sustained at 1 year with 87.1 showed at least 1 grade improvement at 1 year, 70% moderate or less TR at 1 year. It showed continuous and sustained symptomatic improvement and quality of life, with improvement from quarter to almost 83%. Also, this led to reduced hospitalization rate and indirectly improved survival. So the most prominent and striking features of this study is reduction in the right atrium and right ventricular dimension with significant improvement in the RV function, suggesting positive remodeling. We observe it in the pulmonary hypertension ward that we can reverse the RV remodeling. After the triluminate pivotal trial, TriClip became first device of its kind to receive CE mark for minimally invasive tricuspid valve repair. And moving to real-world data, B-Right study group introduced the study B-Right, initiated to evaluate real-world safety and effectiveness in patients treated with the TriClip and the TriClip G4 system. B-Right's study included 200 patients, mean age of 78.4, 51% were female and they have the traditional risk factor. Almost more than quarter have bright mitral intervention and almost half percutaneous intervention. 82% patient has functional class 3 or 4. Left ventricular ejection fraction was 55.6 and the PA pressure was 38.8. Acute procedural success was achieved in majority of the patient, 90% of subject successfully meeting the primary endpoint performance goal of 75%. You can observe here the clip usage was mostly XT, and this is because of the TriClip G4 was introduced late in the study, so and only used in 14 out of 200 patients, only 7%. 90% of subjects had TR reduced by at least 1 grade at 30 days, with the majority reduced to moderate or less. Majority of subjects experienced significant improvement in New York Heart Association function class and quality of life. So moving from the study, we're still early in the learning curve with the TriClip system, and we did not yet achieve the success rate we observed in the mitral space. So mitral space, the success rate is almost 97% or more, but in tricuspid clip, we reach up to 90%. And the most important predictive factor for failure in patient with the TriClip is the coaptation gap. So the TriClip system is all about closing the gap, and multiple technique has improved to target the coaptation gap. One of them is the using of the new G4 system with the independent grasper that improve grasping of the leaflet independently during the procedure. The other thing is the introduction of the wider clips, including the NTW and XTW that was integrated in the new 4G system. Always looking for the procedure to be successful is bringing the patient and diaries prior to the procedure, repeating the right heart cath before planning for the tricuspid clip. During the procedure, allowing the tidal volume to decrease and minimize the passive cardiac movement during the procedure. And the other technique is zipping technique with placing a clip between the anterior and septal toward the commissured, then moving inward to close the gap. This is one of the things to improve success rate in difficult coaptation gap. This is a recently published study done showing that minimal technique to minimize the coaptation gap is by tilting the table by 10 degree, and this has led to significant improvement in the gap size and the gap area. In summary, transcatheter edge-to-edge repair using TriClip device is a promising technique that has demonstrated procedural feasibility, early safety, and satisfactory midterm outcome. However, some issue at patient selection, optimization of inter-procedural result, and long-term data should be addressed in the future studies. By this, we conclude our talk. Thank you so much.